First of all, I would like to thank AIOS for giving me this opportunity. With due respect to the chair, and I welcome all the delegates here and all dear speakers of this session. So I start with the keynote address to you. So we are taking today surgical solutions in retinal vascular disorders. So we all know what's the vascular supply, the ophthalmic artery, the central retinal artery, the various parts, and how it goes about and gives branches, the posterior ciliary artery, and how it divides and supply the retina in both halves. The central retinal artery goes in the optic nerve. First it is in the central part and then goes nasally and then divides and supplies the retina. So first of all, I would like to take the retinal occlusions. I think this is being taken up by Dr. Sangeet Mittal, and they are arterial and venous occlusions. Central retinal artery occlusion, it's a rare event. It's like a MI of the eye, and it is the atherosclerosis which is implicated in this disease. Branch retinal artery, it is a common disorder of the ocular vasculature. It stems from the occlusion of a branch of the central retinal artery. There is a focal loss of vision, acute onset of painless monocular vision loss or visual field loss. So mainstay of treatment is medical, but surgical techniques have also been explored. Anti-YAG laser arteriotomy is done. There are two methods of this. We achieve phagofragmentation, and where there is no visible vitreous hemorrhage, and we can create a direct visible removal of the embolus from the arteriole into the vitreous cavity, and it leads to limited vitreous hemorrhage. Carotid endarterectomy is done whenever it is indicated. Cannulation of the central retinal artery is a novel surgical approach that allows direct mechanical access to the site of obstruction. This method presents the advantage of avoiding the risk of neurological complications associated with selective thrombolysis. Vitreous surgery is done sometimes for central retinal artery occlusion. There is a special shaft-like thing, and over that there is a stylet which goes into the substance of the optic nerve, and it clears off, it presses upon the embolus, and the occlusion is gone. After standard 3-port pars plana vitrectomy, a specially designed probe was used to massage, in this particular study, the central retinal artery on the optic nerve head or within the optic nerve, or both. Vitreous surgery is also done with the central retinal artery without the shaft, with the help of a direct cannula. This cannula goes direct into the central retinal artery and dislodges the embolus. These are the pictures which show that how it improves the central retinal artery after this cannulation. The retina seems to be normal now. Then is the central retinal vein occlusion, CRVO. This is the obstruction of the central vein at the posterior to the lamina cabrosa, affects men and women equally. It's a unilateral disease. Treatment options are various: corticosteroids, intravitreal triamcinolone, and dexamethasone. And half-life of this Ozurdex or this dexamethasone, it is less as compared to intravitreal triamcinolone acetate. Then is the anti-VEGF therapy, and then there is PRP, which can be done in cases of CRVO. If there is ischemic CRVO, there are a lot of CNP areas. PRP can be done after once you see that it is more than 8 optic disc areas of CNPs, go for PRP. Then is the chorioretinal anastomosis, which can be done with the help of green argon laser, power 2.5 to 3.5 watts, which creates a small spot to rupture the Brooks membrane. Second spot is to rupture an adjacent venule, and the two are joined together. So surgical transretinal venae puncture technique can be created through this anastomosis. Intense focal burns can also be made near or tributary vein in an attempt to disrupt the wall of the vein and rupture the underlying Brooks membrane. Then is the radial optic neurotomy. Here there is Oppermack was the first to do this radial optic neurotomy to achieve the decompression of the scleral outlet via an internal vitreoretinal approach. It's thought that it's CRVO. It's similar to a compartment syndrome, and according to this hypothesis, there is a bottleneck existing at the lamina cabrosa, and by making a nick at the medial part of the scleral wall, we can release this bottleneck occlusion. Bottleneck structure is broken and the pressure is released, and thereby it is occlusion is open. Then there is the endoscopic surgery in ophthalmology. It says the same about radial optic neurotomy in CRVOs. Vitrectomy with complete posterior hyaloid removal is done for ischemic central retinal vein occlusions. Vitrectomy eliminates the metabolic agents present in the vitreous as well as the mechanical traction. In this way, we might protect against retinal and optic disc neovascularizations. Then there is TPA injections in eyes with CRVO. Then is the branch retinal vein occlusion. Similarly, we can do laser, scatter laser photocoagulation, intraocular corticosteroids can be used. Anti-VEGFs are another option with us. But then it is important to know about these surgical procedures, which is the topic of today's program. It is arteriovenous adventitial shidotomy can be done where there is arteriole compressing upon the vein. That site is, with the help of a MVR, we can release this gliosis area, and the release of pressure is done. Conventional PP is done for BRVO complications, vitreous hemorrhage, TRD, epiretinal membranes, removal of loculated preretinal subhyaloid hemorrhage, removal of the subfoveal laser-induced choroidal neovascularizations can be carried out by doing a good PPV. So vitrectomy in vascular tumors is the next topic of today, and vascular tumors, there are various. We know choroidal hemangiomas or retinal vascular tumors. So retinal cavernous hemangiomas, AV malformations, retinal capillary hemangioblastomas, and retinal vasoproliferative tumors. Various treatments are available: photodynamic therapies, laser photocoagulation, cryotherapy, plaque brachytherapy for retinal capillary hemangioma hemangioblastoma is available. Triple freeze thaw transconjunctival cryotherapy, laser photocoagulation, PDT anti-VEGFs for retinal vasoproliferative tumors can be done. And also we can do a good vitrectomy to release any ERM or any vitreomacular traction, tractional RD, and if there is hemorrhage, again vitrectomy can be helpful, and endolasers can be applied all around the whatever is the vascular tumor or abnormal vasculature that is taken out. Retinectomy is done, and the surrounding area is lasered properly. This is a picture showing infratemporal vasoproliferative tumor treated with cryotherapy, showing complete regression with residual epiretinal membrane. This is a 2 months post cryotherapy. 6 months after surgery, vision was 20/50 and foveal anatomy was restored in this particular study, which I have taken from the Google. Then is vitrectomy for vasculitis, which is going to be taken up by Dr. Hemant Murthy. He is going to talk on retinal vasculitis. Signs of retinal ischemia, including cottonwood spots and intraretinal hemorrhages, are there. Various stages of vasculitis as inflammation, ischemia, neovascularization, and complications. Indications of vitrectomy in vasculitis: there is persistent or recurrent vitreous hemorrhage, neovascularization, vitreoretinal tractions, and epiretinal membranes. .25-gauge vitrectomy is a useful technique, less aggressive to the eye than conventional vitrectomy. What may be of importance: adequate 25-gauge instruments such as forceps and orientable laser probes allow a less aggressive surgery, and there is a less risk of lens damage. Phacoemulsification, scleral buckling procedures, and cryotherapy can be taken along when we do surgeries for vasculitis. Then is the vitrectomy in tractional retinal detachment. It's to be taken by Dr. Saurabh Luthra, if is there. So all the tractions have to be removed once a good vitrectomy is done. Vitrectomy in tractional retinal detachments, a central vitrectomy, axial opacity and cortical vitreous gel is cleared using vitrector. A large opening is created in the posterior hyaloid until vitreoretinal adhesions are encountered. Segmentation, delamination of these adhesions are done, especially in diabetic TRDs. The dissection for separation of retina from external proliferation proceeds anterior to posterior. This is known as the delamination. Then various other surgical procedures are there for tractional retinal detachments, segmentation, and this is also helped with photocoagulation and with normal fluid air exchange is done. Intravitreal bevacizumab or anti-VEGFs others use adjuvant to any central vitrectomy to reduce bleeding associated with segmentation and delamination. Thank you.